Η ώρα αυτή μας λέει ότι πρέπει να πω καλησπέρα σε όλους. Ευχαριστούμε πάρα πολύ που είστε εδώ σήμερα. Η δεύτερη κλινική μαστού του ΙΑΣΩ ακολουθεί κάποια εκπαιδευτικά προγράμματα, ένα εκπαιδευτικό πρόγραμμα με κάποια σεμινάρια, και ένα από αυτά είναι σήμερα ο πληθυσμιακός έλεγχος. Θα μας μιλήσει ο καθηγητής κύριος Geraghty από την Ιρλανδία και η κυρία Πούλου. Την ημερίδα αυτή τη συντονίζει ο κύριος Παπαδόπουλος Λάζαρος, ο οποίος είναι επιμελητής της Β Κλινικής Μαστού και είναι και Ambassador της ΕSO εδώ στην Ελλάδα. Και θα ακολουθήσουν και άλλα εκπαιδευτικά. Το συνέδριό μας θα γίνει το Δεκέμβριο το Πανελλήνιο που διοργανώνει η κλινική μαζί με την εμείς, και φιλοδοξούμε να συνεχίσουμε αυτή την εκπαίδευση χωρίς σταματημό. Thank you, you be here. We are very glad to have you here, and you can start now.
So, ακούγουμε? Okay, so we'll talk in English from now on because of our distinguished guest that we are honored to have with us today. So we would like to welcome you all in this, we believe, interesting talk, and we will try to deepen into something that Greece, I think, unfortunately lacks in compared with the rest of Europe. And this is a screening program we've started this year, so we are freshers on that, and we would like to hear the opinion from somebody who's been doing that for decades on the one hand. And on the other hand, unfortunately, we don't have any registries, any cancer registries. I mean, if somebody from Ireland was to ask me how many cases of breast cancer did we have last year in Greece, I'm not going to be able to give an answer on that. And thirdly, we don't have any national guidelines. So these are issues that they've been dealing with, and in Ireland they have their own screening program. They've been doing that for almost 20 years. It has its pros and cons, and we will talk about their experience and the things that they have learned, the things that they imply in their everyday practice, and maybe learn something from that. And Mr. Geraghty, which I had the honor as a fellow during my fellowship in Ireland, I had him as a consultant. He's a breast surgeon, he's a consultant, and he's also in the University College of Dublin. He's a professor of surgery, and he will talk about the national guidelines in Ireland, and he will talk about their national screening program and the things that they've learned and their future perspectives. And then Mrs. Pulu, we all know her, is a well-known breast radiologist here in our department and in our hospital. We'll talk about the current trials with different modalities that right now are being happening, or we have any results. So, Mr. Geraghty, it's such a great honor to have you with us here, sir.
Thank you very much, everybody, for inviting me to speak today. It's really fantastic to be here in Athens. I am very sorry that I brought some of the Irish weather with us here. It's a little bit colder than normal, so you can blame the Irish influence here. I remember the first time I gave a talk for the European School of Oncology many years ago. I was invited to give a talk in my first time in Greece in Ioannina, northern Greece with Nico Pavlidis. He was a guy, I don't know if you know Nico, but I was asked to chair a session, and I couldn't believe it. It was snowing. I said, "This is not possible. This is Greece. How can it snow?" But here we are, and Ireland and Greek people, I think we're very similar. We relaxed, take it easy, enjoy the wine and the food. The horses, of course, I have heard, the horses, yes. Fresh from his success in the local derby, so well done. So it's really nice to be here and use the opportunity to share our experience. I wasn't actually aware that you were starting a screening program in Greece, so it's very opportune for me to tell you how good screening programs are, but also maybe how screening programs have lots of problems as well, and there are issues with that. So over the next half an hour, I'm going to share our experience with you in Ireland, tell you a little bit about Ireland and our cancer program, and then to talk about the pros and cons of screening. So, in a nutshell, I suppose if you're in Greece or if you're in Ireland and if you want to start screening, whether it's prostate, breast, colorectal, you can do it in different ways. You can be opportunistic. A lot of hospitals in Ireland, and I'm sure in Greece, do screening within the hospital. So you have a screening program within the hospital, a mammogram, a PSA, a colonoscopy, for example. Other groups have what we would call risk-based screening. In other words, you have a patient who is at a high risk of developing cancer, and you screen those patients. Classic ones would be those that are carrying the breast cancer genes, who have a 50 to 80% chance of developing breast cancer, or patients with a previous breast cancer. So it seems very reasonable to have a screening program for these type of patients. But the main programs around Europe, and the one I'm going to talk about today, is population-based screening. That means it's not about your risk, it's not about anything else, it's about your age. And population-based screening in Ireland and in different parts around the world, it varies. But in Ireland, we start at the age of 50. So a woman at the age of 50 is invited to have a mammogram every 2 years. And that's how it works. So once you reach the age of 50, sometimes a little bit later than 50, then you enter into a screening program. So population-based screening is for everybody. The other types of screening are for selective groups. I just want to tell you a little bit about breast cancer in Ireland, and I'm sure there are interesting comparisons with Greece. I would have said that certainly when I started off my training, we had so many different hospitals doing breast cancer surgery. We had maybe 25, 30 hospitals doing breast cancer surgery. All general surgeons did breast cancer. So I'm actually a general surgeon. I do emergency call, but my major interest is breast cancer. But in years gone by, general surgeons would do breast cancer, and you might end up doing 5, 10, 15, 20 cancers a year, or you might end up doing 100 breast cancers a year. And the problem with that is that there were certainly some high-profile cases in Ireland where there were some legal issues, delay in diagnosis, mistreatment, etc. And because of that, a lot of attention was put into seeing, can we regularize the management of breast cancer? So two things happened. In 2002, we set up the National Breast Screening Program. So in 2002, which is 20 years ago, breast screening started. In other words, women were sent out a letter to say you were to have a mammogram, inviting them to have a mammogram every 2 years. The issue about the symptomatic breast cancers, not screening, but symptomatic breast cancers, was a political nightmare, because the problem, as you can imagine, is that the hospitals in the west of Ireland or in other parts of Ireland that were doing 25, 30 cancers a year, then they're saying, well, we're doing a nice job. We want to continue doing breast cancer. And then the health service were saying, you're not doing enough cancers for quality assurance, so I'm afraid you have to stop. And then the politicians come in, and then the politicians say, we're not closing this breast unit. So this was a very difficult time in Ireland. But at the end of the day, in 2008, we set up the National Cancer Control Programme. And that meant that only 8 hospitals in Ireland could do breast cancer. All the other hospitals closed their doors to the management of breast cancer. So that was politically very difficult, but I can tell you that this was hugely beneficial to the patients, even though it was very difficult for everybody else. This is my hospital here, as Lazarus knows well. The main campus is here. This is the whole main campus here, with many different buildings. There's our main campus, there's buildings for patients, buildings for radiotherapy, for chemotherapy. We have a private hospital as well, which is over here. And just to show you here then, this is the National Breast Screening Programme building here. So that's actually quite a big building, and that is dedicated just to the management of breast cancer patients. So we do our hard day's work here, we work in the hospital, and then at the end of the day, we jump over the wall, and there's a golf course here, so we can play a game of golf at the end of our hard day's work. But our hospital is affiliated to the University College Dublin. In our hospital, we would do about 750 cancers a year. I think this hospital is something similar from what I heard. Yeah, similar. We do 750 a year. The difference, of course, is that we have a mixture of 3 different populations. Number 1, screen-detected breast cancer patients. Number 2, symptomatic, you come with a lump. And number 3, some private patients as well. But I would have said that out of the 750, maybe 600 are public patients, and then 150 are managed in the private hospital. So therefore, those 600 patients, they come for to come to the clinic. The treatment in the fee in the clinic is 0. They have their surgery, no fees. Hospital, no fees. Chemotherapy, no fees. So everything in the health sector is free to the patient. And of course, the big issue, as I'm sure is in Greece as well, that's all very fine, but can you access the service? It's very difficult to access these services. Lazarus has met most of our surgeons, sadly lost one last year, which was a very sad, tragic loss, my colleague Enda McDermott. Now we are 5, and then we have 12 theatre sessions, and as Lazarus knows, 100,000 breast clinics every week, which keep us all very busy. Now, part of our remit as well is that we train breast surgeons, and I was saying to Lazarus earlier, and perhaps to you as well, that if anybody does want to spend some time with us, this is for the residents here, then you're very welcome. We can talk afterwards, but you'd be very welcome to come. But we train all our surgeons within our hospitals. This is the Royal College of Surgeons in Ireland. I'm on the council of the college, and we train all of our surgeons. So we would have trainees that would come to our unit. We'd have in our hospital 25, 30, 40 trainees. And these are young doctors that have gone through an interview process at basic surgical training, age of 22, 24, 25. They then do an interview process, and if they succeed there, then they go into what we call higher surgical training, and they become a consultant like myself within the period of 10 years. So it's quite a flat system in Ireland. We have all of these consultants who are pretty much similar. Now, in terms of breast checks, so we started in 2002, and we decided that we'd have 4 hospitals, which I'll show you in a moment, 4 hospitals dedicated to the management of breast screening cancer patients, and mobile units, which I'll come back to. I met some of our radiology colleagues earlier. Very nice to see you again. So we have dedicated radiologists. They just do breast cancer radiology. Now, it was a bit like I mentioned with surgeons before, and surgeons doing everything, and our radiologists did everything, and then you have a missed cancer or whatever else. Now, it's just breast radiologists. So they're specialized just to do breast radiology, nothing else. Some do some general. All our x-rays, all our radiology is double read. So that means that radiologist A reads the mammogram, and then radiologist B separately reads the mammogram without the knowledge of what A says. Then they both agree, and if you have a double read, then you have agreement that this is the finding. Our screening program starts at the age of 50 and goes on now until the age of 70. So it was 65 years, is now 70. The problem, we have a population of 5, maybe 6 million, so the problem with if you go from 65 to 70 politically is that that's very appropriate. I mean, a 70-year-old is still, I hope, a youngish woman. They should have screening, but I think the interval of 5 years, I think, costs about 25 million. So to do so, to roll out screening for another 5 years, about 25 million. We do mammography every 2 years. We had a discussion earlier, do you do it every year, do you do it every 2 years? We'd like to do it every year, but if it's every year, it's twice as expensive. Every 2 years, fine. The UK do it every 3 years. So it varies between different centres, and some centres start at 40. The United States starts at 40. We start at 50. So there are lots of debates as to the interval in screening. We have a weekly multidisciplinary meeting, so all of our patients that have a cancer diagnosis but also have a benign diagnosis are discussed prior to surgery or any procedure. So you may not proceed with a decision about the patient until that patient is discussed. Because our volume is so great, we now have a team meeting on Monday afternoon where we discuss maybe 50, 60 patients. And then our symptomatic multidisciplinary meeting is on a Friday, I think the same as yourself, and we now have 70 or 80 patients discussed at that. So it's actually quite long and it's quite cumbersome, but it does give the opportunity to the patient to have the input of everybody to decide how that patient should be managed. And I think that this input before surgery as well as after surgery is quite important. I'll talk about quality assurance, which is obviously the key to all of this. These are our 4 centres. So we've got 2, this is Ireland here, 2 in Dublin. Our one is the biggest one. And then we've got 1 in Galway, which is the west of Ireland here, lovely place to visit. And then 1 in Cork, where I'm from. So we've got 4 units around the country, and they screen every day. In terms of screening, then the patient doesn't come to the hospital. That doesn't happen in screening. The hospital goes to the patient. So what we have is 25 of these units, mobile homes, you could call them, I suppose, and they move wheels, they move around the country. And the places they go largely are big shopping areas. So a patient would be invited for their screening. They'd say, we're in the local Athens, big Athens shopping area on next Thursday and Friday, and then the patients would come and they'd have their mammogram inside in this building. These mammograms are then all uploaded onto an IT system, and then these are sent to the 4 screening units, where the mammograms are then read within the screening units by the radiologist. So this is a great system where, people will not travel all this distance to these places. So we bring the mobile units to the patient. So if you are, I'm not sure maybe we can talk at questions, what the plans are for Greece, but I think you really have to have these units, or else it won't succeed. Some data, and I don't want to read all of this data, but I just want to say to you that this is all about a women's charter. So in other words, the women and indeed the committees decide how women should be looked after as part of the charter, and what are the performance indicators. How do we tell a woman that this is a good service? And I won't go through all of this. I did bring some reports with me, which I will leave with you, which you can see for yourselves, some historical reports which outline all of these. But just to say to you, as an example, we have a performance parameter here. Some of these slides are of the same format. Performance parameter here and the standard here. So in other words, we're saying to the patient, we're saying to the community that this is our intention and that this is the standard. It must be greater than, these are all greater than 90% here. So we must achieve that standard. And we meet once a year, a quality assurance meeting. We go through all our figures, and if it's not up to standard, then we have to discuss it. And some of it, without going through everything here, but some of the things would be, did a woman receive their appointment within 7 days of receiving correspondence. Were they sent the results within 3 weeks? So in other words, you have a mammogram done and you wait for 3 months. That's no good. So you need to know within 3 weeks. Women often an appointment after an abnormal mammogram is found, etc., etc. So I don't want to go through those, but just to make the point that this is a screening program in which quality assurance is mandatory. Now, this is a slide showing historically our numbers. I think you're saying you're starting now, so your start date is 2022. So we're 20 years down the line. I'm up to 2019. Something bad happened in 2020 and 21, as you know. So the screening program just practically stopped in that period of time, and a very bad time for Lazarus and others to come to visit, which was a pity. But we started off in 2002. This is the number of patients invited. This is the number who invited initially. You're 50 years of age, we're inviting you to have a mammogram, and these are the ones then that are having their subsequent mammograms at 52, 54, 56, 58. So as you can see, we started small, 43,000 people initially invited, and all of that. But now that number has increased greatly. And as you can imagine, the number of subsequent women invited increases because each 2 years you get invited. So at this point in time, where our figures are quite high here, and they took a real dip in obviously in 20 and 21. These are the numbers that were screened. So we invited a certain number of women, but please remember that a lot of women won't attend. They're afraid of having a mammogram, like we're afraid in case they find something. So the numbers of patients that are screened are actually, they're still high, but there still were a lot less than the numbers that were invited. Now, in terms of these, again, is quality assurance. So if you're setting up a screening program, I'm not sure how you'll do it here, but it's really all about quality assurance, and everything that we do has to be quality assured. So this is the performance parameter, and this is the standard that's accepted. I won't go through all of these in great detail, but we look at how good is the standard of this setup on the basis of a number of parameters. The number of open benign biopsies, I'll come back to that later. The open benign biopsy rate per 1,000 women screened, the number of women diagnosed with breast cancer, the cancer detection rate, something I'll come back to, the number of patients with ductal carcinoma in situ, and all these figures here. But you see on the right side here, this is the standard that you accept. So less than this percent, less than 7% for open biopsies, and we're 9, 10%, not great. Same thing here with a few of these. So we measured our performance, we look at this every year, and then we decide how to change things. This is the same slide, and once again it shows the performance parameters which we use for patients that are having a subsequent screen and not the initial screen. I think, as I mentioned earlier, you expect that not everybody will take this up. And, you know, we're all human, we're all afraid of having a test in case you might find something. So there is a fear of having mammography. And I think it's a fear of having a cancer. And for that reason, they don't take this up. So I would think that if you're setting it up here, then your uptake rate would be, you'd be doing well if 70% of women take up breast screening. So 30% won't. There's a number of other reasons behind that. But once you're in the screening program, once we get you into the program, then the number who attend are obviously much higher. So once you get them past this point, then the majority of people will come for their second, third, fourth, and subsequent mammograms. The data are inputted by each unit and by each screening van, as it were. So we can have data as to the uptake within the country. So you can see that this is high uptake. This is a place called Wexford. The sunny, we call it the sunny southeast. It's the closest thing to Greece that we have, I think, in Ireland, which is Wexford. And then this is the West Coast and Mayo, Sligo. These are counties in which there's sparse population, and perhaps they don't attend our screening as much. Now, I'd just like to take you through what happens to a patient when they're recalled. So the patient goes into the van. They have a mammogram done. It's read, and they see something. What happens then is that patient is then sent a subsequent letter, which is a tough letter to get, saying that we found something, you need to come in. So then they come into the clinic, and this is just an example of what we do within the clinic. We have a clinic assessment data sheet here, and I do this 20, 25 times a week. So I do this. So you have to tick all of these boxes. You tick, so that there is a screening abnormality. Is there anything found on examination? Normally that's normal. In other words, you can't feel the cancer because it's so small. Does it correlate with the mammogram? This is the international classification for clinical findings. S1 is normal. S5, examination, you think is cancer. Most of these, the examination is normal. We talk about family history. We then have the clinic assessment outcome here, and then we have a multidisciplinary meeting where we decide the patient either is to come back in 2 years' time, to be called back in 6 months or a year, or to have further assessment. So the data that you have seen there is a result of these boxes being ticked. Now, the issue behind that, of course, is that in our unit, in our screening unit, then there's a big secretarial layer above us, where all of this is inputted and analysed on a weekly basis. In terms of how many patients are called back, so in other words, you have your mammogram and you're called back, and this is very relevant, I think, to our radiology colleagues here. So this is the recall rate. In other words, you have your mammogram. How many people are called back? So 3%, roughly, or from 2020 to 2019, around 3% keep getting called back for subsequent. That means you have your mammogram initially, then you have your mammogram in 2 years' time, 4, 6, 8, and you would expect that you compare the new with the old, you would expect that the recall rate would be a lot less. The problem is, and I'll talk about this later, the problem is that our recall rate, which should be around 5%, that line there, our recall rate is just going up and up and up, and perhaps our radiology colleagues can comment on that. But I think this is good news in one sense, in that new imaging modalities such as tomosynthesis, which we had a chat about earlier, they increase the sensitivity of mammography. Great news, more cancers. Bad news, more benign disease and more recall. So this is a big minus of the screening program. So what would you expect? I won't go through this in any great detail, but these are the number of cancers that have been diagnosed in Ireland since the screening program started. So these are the patients over the age of 50 have had a diagnosis of breast cancer on an annual basis. 2002, number of cancers, this light blue is invasive, and the total is that number, and these are pre-invasive or ductal carcinoma in situ. So you can see we started off small here, and then obviously the number is almost 1,500 each year in Ireland. So a lot of cancers, we diagnose a lot of cancers in Ireland. I mentioned that we have 8 units. 4 are symptomatic and screening, and the other 4 are just symptomatic, not screening. So we take away actually quite a lot of cancers from these units because we pick up a lot of the cancers from 50 to 68 because they're brought into the screening program. Now, one of the big issues, of course, is which we'll talk in a moment, is overdiagnosis, and that means that how many patients in which we do a mammogram and we do a biopsy, how many patients have surgery for ductal carcinoma in situ, pre-invasive cancer, and not an invasive cancer. So the guideline would be that you would expect around 20% of your cancers to be ductal carcinoma in situ. So if you're setting up a screening program, then you would expect that 80% of your cancers will be invasive, but that 20% will be pre-invasive, or whatever the word is. And this is pretty standard, and this has been pretty standard over the years. And this is one of the issues, as I mentioned previously, with over-treatment, in that, you know, are you helping these patients? Is it a good thing or a bad thing to diagnose ductal carcinoma in situ? Well, I guess it all depends really on the type of ductal carcinoma in situ that you have. We use the international classification is low, intermediate, or high-grade ductal carcinoma in situ. And these are the data for us for 2018 and 19. And just to say that 67%, 57 subsequent, that over 60% of our patients have high-grade ductal carcinoma in situ. So high-grade are more likely to develop into an invasive cancer. So maybe these are the patients we should be doing. Maybe these are the patients we should not be doing something on, but that's for discussion. Non-operative diagnosis is a big performance indicator. So it would be, for us professionally, whether it's symptomatic or screening, to operate on a patient without a preoperative diagnosis of breast cancer is, you can't do that. That would be very, very bad news, and you'd be questioned about that, because you know you need to plan your surgery. So Ireland is very fortunate in that. I'm not sure what it's like here, but I can tell you in the United States, for example, a lot of patients come to places like Memorial Sloan Kettering with a diagnosis already, and then they refer on. So they have a lumpectomy, it's removed, and then they present. But the guideline should be, in subsequent screenings here, the guideline should be that only 2 or 3% of patients should have a diagnosis made with an operation. In other words, you've got a lesion, we're not sure what it is, we've done an operation, we find it's a cancer. That should be 2 or 3% maximum. This figure is another of the patient charter ones, and that is the women offered a hospital admission within 3 weeks of a diagnosis of cancer. This is, the guideline should be 90% should be offered an appointment within 3 weeks. We're pretty good here generally, but this has really gone pretty bad over the last 2 or 3 years. We're trying to play catch up after the pandemic, but I would have said that our guideline is pretty much adhered to there. So that's a little bit about Ireland and screening. Now, is it all good news? Well, it's not all good news, and I'd like to give you some reflections, personal reflections, and it's interesting that you're starting up, and also some international reflections. There are 4 big issues with screening. The first is overdiagnosis. So, and I'll come to that in a moment. Are you diagnosing too many breast cancers? That's a strange comment to make. The second is that you're recalling people that are actually okay. The third are interval cancers, which I don't have time to deal with today, but can talk about it. And the fourth, again, is exposure to harmful treatments, which I won't discuss in any great detail. Overdiagnosis is a very simple concept, and that is, think of it like this, that a woman comes in, she has her mammogram, she has her biopsy, it shows that it's a cancer, but actually that cancer would make no difference to the patient if it wasn't diagnosed. In other words, the patient would have had a full life without a diagnosis of a breast cancer. And who are these people? And perhaps a lot of ductal carcinoma in situ patients are like that. So do we overdiagnose too many cancers? It's a strange thing to say. Should we be operating all patients with pre-invasive breast cancer? If we overdiagnose, are we causing harm to these patients? And if you make a diagnosis of a breast, let's say you have a ductal carcinoma in situ patient, and they end up with, they have 40 millimeters of ductal carcinoma in situ, you do a wide local excision, the margins are positive, you end up with a mastectomy, you do reconstruction, and all of that. And actually, the patient didn't need this procedure done at all. So you've harmed the patient psychologically, you've harmed the patient with surgery, with radiotherapy. I've had, in the last, at our grand rounds, I had 2 consecutive patients who were 20 years down the line who had radiotherapy for breast cancer and came with angiosarcoma of the breast, which was a bit of a disaster. So radiotherapy does cause issues, and then obviously adjuvant hormonal therapy with all its side effects. So this is the data. And I put this together as best I can for you about overdiagnosis. This is from a UK independent panel, and these are some meta-analysis. And this is what I'd like you to see here. And it is the ratio of a patient dying of a breast cancer to those that you overdiagnose. In other words, that for every death that you can avoid, death, not diagnosis, every death that you can avoid, how many do you overtreat? And the literature is it's a bit variable, but here, for example, in this UK independent study, it was 1 in 3. So for every averted death from breast cancer due to screening, you overtreated 3 people. And these figures vary a little bit here, but they're pretty much similar. And here you have the estimates of overdiagnosis to mammography. And the problem is that if you look at randomized controlled trials, cohort studies, etc., the problem is that the overdiagnosis incidence is very high. I said maybe it's 1 in 3. But here, in this study here, it was up to 76%. And in these modeling studies here, it's 30%. So it varies a lot. So I've tried, just for this talk, I've tried to simplify matters and look at the data. And what I would say to you is that the lesson that we've learned is that for every breast cancer death that's averted, 2.5 cases are overdiagnosed. So in other words, we overtreat 2.5 cases for every breast cancer that's diagnosed. So which side, something to discuss, which side of the fence are you on? Before I finish, 1 or 2 other quick things. False positive recall is an unusual term, but what that means is that you have your mammogram, they find something, but it's actually nothing, but you have a biopsy, and maybe the biopsy shows that it is something, and then you have a surgery that's unnecessary. Let's say, I don't know what classification you use here in pathology, but we would have B1, B2, B3, B4, B5. So B3, A or B means that they're atypical cells, but they're not cancer. What do you do with those? Do you remove them? Do you leave them? Well, we remove them. So that's a diagnostic operation. It's undue anxiety, but the chance of having a recall are quite high. So you really are upsetting a lot of patients psychologically. For what price? That's the question. Now, this is a graph that I hope will change, but I looked at this. This is from 2012. I'm sure it's changed since. And it looks at the non-population-based screening program. So I hope, and I didn't know this until today, that you will now start, because there's very few countries that don't have population-based screening programs. But what I would say to you is that just be careful, because screening is good, but you've heard the downside of screening as well. So to summarize, in my own personal experience, I've been 20 years, I was part of the setup of the screening program. It does save lives, and you really have to look at the benefit-harm ratio of these patients and the cost. What I would say to you is that maybe risk-based screening will be the way to go in the future. I mean, this is population-based screening is your age. 50 to 65, 50 to 70, you have a mammogram. But what if you're 40 and you have a very strong family history, or you're 40 and you're overweight, as you have a gynecological service here. So there's you know, if you have that, or if you're carrying the breast cancer gene, so it may well be that we will start doing other ways of screening other than population-based screening, and it's really important that people know that they consent. In other words, that when they're consenting for a mammogram, that they know what the pros and cons are. So to finish this, I was on my way to work last week, and this was in the morning, and this is a slide of Dublin Bay. I thought I'd show you this, Lazarus, to remind you. This is the sun rising in places that you may have gone windsurfing. But just to say, it's a pleasure to be here. I hope you've enjoyed and learned a little bit about our experience in terms of not what the good aspects are, but what the bad aspects are, from the point of view of the trainees I mean, I would say to you, it's up to you to decide, but very, very happy to have you over for a week and to see what we're doing, whether it's radiology or pathology. See them nodding there. You like Dublin, I think, and the good fun in Dublin. And also, you know, I hope you also get a chance to visit our country. It's not quite as warm here, but I think it is as scenic. So thank you very much for your time.